Good morning. Welcome, everybody. As this webinar is getting started, my name is Tony McDowell. I'm the Executive Director for the Virginia Opioid Abatement Authority, and I'd like to welcome you to this installment of the OAA's Abatement Academy. So the Abatement Academy is a series of webinars that present best practices in opioid and substance use prevention strategies across Virginia, and it highlights certain efforts that are being funded with opioid settlement funds across the Commonwealth. Our speakers generously give of their own time and expertise to make these presentations possible. Like all Abatement Academy webinars, today's session is being recorded, and both the recording and the presentation itself will be uploaded to the OAA's website after the webinar ends. And then an email will be sent out to anyone and everyone who registered for the webinar, providing you a link so that you can access these materials. During the course of the webinar, if you have any questions, please feel free to type them into the Q&A feature on the Zoom platform, and I'll be monitoring those questions and answers and acting as a moderator for the presentation. I'll ask those questions either during the presentation or, if it seems more appropriate, towards the end. And at the end of the presentation, we'll specifically solicit if there's any questions that you guys have, to type them into the Q&A. So today's presentation is going to focus on the University of Virginia, or UVA's, the health system's SmART clinic. And that acronym SmART stands for Street Medicine, Access, Reduction, and Treatment Project. Our speakers are Dr. Andrew Legan and Ms. Alanna Baker. So Dr. J. Andrew Legan, MD, is an assistant professor of psychiatry and has completed his undergraduate degree at James Madison University. He completed his medical degree at the University of Virginia School of Medicine. Then he completed his psychiatry residency and an addiction medicine fellowship at the University of Virginia. Dr. Legan leads the Addiction Medicine Consult Service, and he's also involved in community outreach and has a walk-in addiction clinic at the Haven, which is a day shelter that we're going to be hearing about during the presentation today. Dr. Legan's joined by Alanna Baker, who is a licensed clinical social worker, dedicated and accomplished professional in the field of social work, specializing in trauma-informed substance use disorder treatment. Alanna holds a Bachelor of Science in Business Administration from Indiana Institute of Technology and a Master of Science in Social Work, where she specialized in substance use disorder counseling from the University of Louisville. She's been a licensed clinical social worker in Virginia since 2021. During her social work career, Alanna has had the opportunity to work with a diverse client population in the settings of substance use disorder treatment, crisis intervention assessments and counseling, medical social work, and community mental health services. Currently, she serves as an addictions counselor with the UVA health system, where she plays a pivotal role in the outpatient addiction medicine clinic utilizing harm reduction methodology. So again, thank you so much for our speakers. And with this, I will turn it over to the team. Thank you.
Good morning, everyone. All right. So welcome to the presentation today. We are located in Charlottesville, Virginia, obviously. And something interesting to note is Charlottesville does not have a year-round overnight shelter for our unhoused population. We do have a winter shelter, which typically goes from either end of October, beginning of November, typically when that cold front really starts to move in, and then it goes to about the end of March, beginning of April. So we have partnered with the Haven. The Haven is a multi-resource day shelter and housing resource center in downtown Charlottesville. So I want to kind of highlight the amazing things that the Haven does. In their day shelter, they do have daily community breakfasts. Doesn't matter where you come from, you want to pop in for some breakfast, and it is delicious breakfast. I can attest to that. Charlottesville also does a daily community lunch. Typically, the churches in the downtown area all take a turn having a lunch each day. The Haven offers it on Friday and Sunday. I will tell you their lunch is just as equally as delicious as their breakfast. They offer showering services as well as hygiene products for showering, laundry services, as well as the laundry products to wash your clothes. It is a mailing address for the guest. They offer storage bins for guests who keep their belongings safe. The only thing that they do not allow is for medication to be kept within those storage bins because people coming and going, they can't guarantee the safety. Daily computer access, and then also access to water and snacks throughout the day. Part of their housing program is housing assistance, the rapid rehousing, the homelessness prevention, housing stabilization. They are a hub for referrals for jobs, mental health resources, counseling resources, ID replacement, the medical clinics, which is on another screen that we'll get to, emergency assistance for clothing, shoes, eyeglasses, and then referrals to other local emergency assistance. All right. And with the medical clinics that we were talking about, because UVA has an amazing partnership with the Haven, they allow us to come in. They allow different groups to come in. So we have a primary care clinic that operates there on Wednesday afternoons, usually from 1 to 4. We have a standalone psychiatry as well as our addiction medicine clinic that's there Wednesday mornings, and we're there from 9 a.m. to 12. We offer walk-ins as well as the individuals that are coming back for medication management. We schedule appointments for them so they know that they're going to be seen. They also have an OB/GYN care clinic that will come out, help get those connected to care. They do have the Department of Social Services that comes out twice a month. They help the guests fill out Medicaid applications, SNAP applications, any other Department of Social Services assistance. They do have a DMV clinic, which will help individuals get connected to IDs, driver's license, their vital records. They also have transportation where they will take them to the DMV if they need to get like updated pictures and whatnot, which is really great because for anyone that works with the unhoused population, those vital records are often a barrier to getting IDs, getting care, getting gainful employment because we need those for our I-9s. All right, so I wanted to take a peek inside the Haven. We typically start off our day in the downstairs, the back room where the tables and chairs are set up. And then as our guests come in, we take them upstairs to the sanctuary. The sanctuary is beautiful. It is quite large, so we kind of set up like little pods all across the sanctuary so we can see multiple people at one time. So when you walk into the Haven and you go down the ramp, this is some of the lovely Haven staff. I actually swiped it from their Facebook page. So these are the friendly faces that you're going to see when you walk in. They do require everyone to just check in, sign in to let the staff know that who's coming in, whether you are a service provider or whether you are a guest for the day. They just like to know who's in the building. And then back in that back office there, that is where they have the storage bins. That's where they keep the hygiene products, the laundry products. And then as the guests come in and sign in for showers, they ask them if they need anything. So they have all of the access to whatever supplies or things that they might need. So the day room is set up for people to hang out. I will say that, people tend to take naps because we do not have a year-round overnight shelter for people to sleep in. So sometimes they stay up at night and then come into the Haven for a safe place to just relax. All right, so I'm going to get to the nitty-gritty of how this project developed. So when I first came on to the addiction medicine department, I noticed that I'd have a lot of patients, both on the medication side for our OBAT, as well as patients that had signed up for therapy services that were having difficulties coming to their appointments. And of course, we want people to be successful. We want them to be able to come to their appointments. So I started asking, you missed your appointment last week. How can I support you? And making sure that you're able to get up here. What's really going on? So it was kind of a several fold here into our community needs assessment. We asked the guests that our patients that came into the clinic, what are the barriers? How do we support you? Is that helping you call Medicaid and set up a taxi? Is that we really need to sit down and discuss like the bus routes from where you're currently located, which buses that you need to take to get here? We have an addiction consult service, which Dr. Legan can talk more about, but basically we go over to those that are in the inpatient or the emergency department and try to get them set up with services right away. So I would ask our patients over there, as we're setting you up for services, how do I best support you to be able to access those services? And then UVA also has a statewide substance use referral helpline. And when people would call in for the helpline, I'd simply ask, I'm going to ask you the questions of how I best support you, how I get you connected to care, regardless of what area that you're located in. And also talk to me about in the past, what has been a factor in being able to access care and access treatment. And obviously, we identified several social drivers of health playing those huge roles to barriers for follow-up care. So Dr. Legan, do you want to hop in here?
Yeah, so there are a lot of challenges with addiction treatment and the unhoused population that our clinic is really trying to address. So one of the big challenges is for those who are unhoused, there can be an inherent mistrust of the healthcare system, and a lot of that comes from stigma and experiences that these people have with the healthcare system. So, a lot of times in the hospital, I like to think of the stigma of addiction as getting better, but still a lot of times in the hospital, there are providers who, might not think of addiction as a biological illness, might think of it as more of a choice. A lot of times, people coming in the hospital who are unhoused, certain providers might think that they're just coming into the hospital to have shelter or food for some time. There a lot of patients are also hesitant to establish what the healthcare system, just because of the criminalization of addiction and homelessness. So a lot of patients are hesitant to seek help with addiction because they're worried that it might result in any sort of criminal action. They're worried they might get in trouble if they disclose that they're using substances. A lot of patients have comorbid substance use and psychiatric problems. So a lot of people who are unhoused and are experiencing mental illness have been involuntarily admitted to psychiatric hospitals in the past. So that can also make it make them really hesitant to try to seek psychiatric care, because in the past they ending up in a hospital that they did not want to be in. So that's something where we're really trying to help build that trust. So I think in the previous slide, we showed pictures of the Haven. So when we go to the Haven, we just sit down in one of the common areas. For the most part, we just let the guests come to us. We don't force anybody into treatment. A lot of times, people will kind of come up and talk to us, just briefly chat. We let them know who we are, what we do. And then, after just having a couple of kind of small conversations over the course of a couple of days or weeks, eventually they kind of will talk to us a little bit more and then start really opening up about the struggles that they're experiencing. For people who are homeless, there are also a lot of challenges actually coming to appointments. So our main addiction clinic, located right next to the main UVA hospital, is really just about a mile away from the Haven. But for a lot of people, that can be really challenging to come to appointments. Public transportation can be confusing to navigate, and it's not always the most reliable. People could walk the mile, but when people are struggling with other medical problems or when there's inclement weather, that can be really challenging. If people miss appointments or need to get in contact with the clinic, that can also be a challenge, as a lot of people don't have cell phones, or if they do, they only work on Wi-Fi, so they're not always readily available, for us to call them back if they even are able to call us and leave a message. And then another challenge that patients have brought up is when they do come to the main clinic, a lot of times they might not have clean clothes, or they might not have been able to shower recently. So they just feel more stigmatized, that people are looking and judging at them. So that can make them more hesitant to come to appointments. So again, that's something that we're really just trying to address by meeting patients where they're at, kind of going out to them, rather than making them come to us to appointments at the clinic. And then there's also just a lot of socioeconomic factors that make it really challenging to get into treatment. So for employment, a lot of people are trying to find jobs. Some people aren't working. Those who are working, it can be hard to get time off from their work. They might have set times that they have to be at work, and can be hard to get away. A lot of patients don't have insurance, even though they would qualify for Medicaid or financial assistance. And then also, just in general, I think one of the unique challenges with addiction in the unhoused population is it's really hard living on the streets. And theoretically, if you can try to save money to help improve your situation, but when you're just in a really bad situation, and using a substance, it's right here, it's available, it's all around. Even though that's not going to help me in the long run, it might help me here in this moment, might help numb me to everything that's going on, might give me just a little bit of joy right here and now. And that can be really hard to resist when you're living on the streets. So yeah, our clinic is really trying to meet people where they're at, really trying to make it easier for patients to access treatment. And then I think just having providers also go to where patients are kind of helps us understand the patients a little bit more, and can help reduce any of that stigma.
All right, so this is when we originally wrote our proposal for this clinic, the components and services of what we envisioned this program to look like. So first, we started out with our outreach and engagement, which is always an ongoing process. But before we officially opened our clinic, all those MOUs in place, we had a team going down there just to hang out, just to have community breakfast, community lunch, having conversations about anything and everything. It can be a conversation about the struggles on the street. It could also be a conversation about, what's your favorite color? What do you like to do? What book did you just recently read? Because where the Haven is at, there's a park across the street. And then right next to that, there is our library. And a lot of our guests love to go into the library, and they love to tell me about the books that they just read. And I absolutely love that. So, because I am a huge avid reader myself. So we hit the streets. We are out there in our tennis shoes, and we're just talking to anyone and everyone. We let people know now that our clinic is officially opened, what our clinic can offer, if they're interested, if they're not, that's perfectly okay. You may know somebody that may be interested. When we do go down there for our hit the streets, not just necessarily the clinic day, because we go down there at many times throughout the week to do follow-ups with some of our participants. Or when I say that the community lunches and the community breakfasts are delicious, I am food motivated. I will go anywhere and hang out with anyone if there's food involved. So we're out there passing out harm reduction supplies, which takes me to the next one. Part of our clinic is if you are at high risk of overdose, meaning with the current state of the supply right now, pretty much everybody is. I'm handing out boxes of naloxone to anyone and everyone. You may not need it, and I'm not here to tell you that you will need it, but you may have a friend or a community partner or community person that may need it, and that's perfectly okay too. I do have some fentanyl and xylazine testing strips that I give out right now. Part of the program is the larger harm reduction, which I'll get to at the very end, but that is what we're doing now. We also will support community members if they have syringes that they need properly disposed of. We give them some guidance on guidance and education on what harm reduction is, because at the heart of harm reduction is meeting people where they're at. I'm not here to judge you. I'm not here to shame you. I just want to keep you safe. And what does that mean? So having the education of how do you use this box of naloxone? What does safer use mean? How do we use those testing strips? Because you can give out those testing strips, but if you don't know how to use them, it's not actually going to help you, because there is a proper way to use those testing strips. So we also are really proud of the medical care and the coordination to medical care. I think our medical staff, Dr. Legan and the psychiatrist and the fellow that comes out there are really great in trying to support that coordination of care. I will help you with the expertise that I have. And I also recognize, hey, maybe this warrants maybe a referral. Can we get you connected to our primary care clinic that comes in the afternoon? Can we get you connected to the infectious disease clinic or neurology or cardiology? And the medical providers are so wonderful and just, well, let's put the referral in. And I think that is so incredibly helpful. We'll check someone's blood pressure, and instead of asking them why aren't you taking your medication, or shaming them because their blood pressure is high, it's, hey friend, like how do I support you? Are you okay with where you're at right now? Let's talk about like some of the risks of having high blood pressure, and how can we support, and whatever your goal for your blood pressure might be. The access to the medication, and I'm going to let Dr. Legan take the medication one because it's way outside my area of expertise. I can tell you about it, but hey, he's much better at it, obviously. I'll finish this and then we'll go back to the medications. The counseling and mental health support. We have a psychology student that's with us now. You'll see him on a screen, and we talk about how sometimes counseling therapy looks a little bit different when we're meeting people where they're at. So therapy looks different in our clinic than therapy down here is going to look, where we're doing more relapse prevention or life skills, or talking about what does a craving feel like. It is hard to do trauma work when we're still actively in a traumatic situation. So it just looks a little bit different because we're just meeting people exactly right where they're at. And then we do have an amazing patient navigator who helps with the case management, filling out applications, coordinating care, doing those financial screenings. Particularly proud of, once she joined the team, she's been able to get 8 individuals in a permanent housing situation. And I just think that that's absolutely amazing, and it attests to the community partners that she has and the work that she's been doing. So And then that follow-up care, coordinating with all of the outside providers, outside agencies. We love to be able to work with other agencies to get patients connected to exactly what's going to support them the most. So, Dr. Legan, do you want to talk about the medications?
Yeah. So in terms of medication, really trying to reduce any barriers that exist to be able to have patients have access to medications to treat their opioid use disorder. So the main medication that we use is Suboxone, buprenorphine, naloxone. And there's a pharmacy that is just a few blocks away from the shelter that we will often send the Suboxone to. I think having access to these medications is just really important. So I think Alanna mentioned that I'm part of the addiction consult service at the hospital. So essentially what that is anybody who comes into the UVA hospital and has any sort of problem with substances, whether it be opioids or alcohol, me and my team can go see them. And so a lot of times in the hospital, people are coming in, withdrawing from opioids. Usually they're admitted for sequela of their substance use, whether that be oftentimes it's infection. So we help manage that withdrawal, and then can also treat the opioid use disorder, kind of getting people started on Suboxone. And it's all good and well getting people started on Suboxone, but they need follow-up care. So we can send referrals over to the main addiction clinic, but then I also, let people know that I also operate a walk-in clinic at the Haven. And if it's easier for them to meet me there, then I just see them in the following week or two and can continue that prescription of Suboxone. We also do offer naltrexone, which is another great medication. It is harder to get people started on naltrexone, so not too many people are on that. We unfortunately cannot do methadone because we don't have a methadone clinic at UVA. And then, a lot of people who struggle with opioid use struggle with other substances too. So we see people who are struggling with alcohol and can prescribe naltrexone, acamprosate for that. Stimulant use like methamphetamine really seems to be on the rise. And so there's nothing that's FDA approved to treat methamphetamine use disorder, but there are a couple of medications that we use off label. And then we do have the psychiatry team with us there as well. And I think it was mentioned, I am also a psychiatrist. So a lot of times if people have unmet mental health needs, psychiatric problems that can lead them to the substance use or can be a trigger. So we also offer treatment for any other psychiatric problems that are going on and might be contributing to their substance use. So here's a picture of our group taken just yesterday. I'm the psychiatry attending. I will often have trainees with me as well. So currently, our addiction medicine fellow, Dr. Ali, comes with us to the Haven. So she'll see any patient struggling with substance use disorder. I also have Dr. Sarah Polly, a fourth-year psychiatry resident, who comes with me and sees people, more struggling with the mental health aspect. I'm currently, the attending for both the addiction and the psychiatry side of things, but I think we will soon have another attending do kind of more of the psychiatry, and I'll do more of the addiction. And then we have Alanna Baker here. She's really fantastic, and we'll meet with people for therapy. Medications are great and all, but a lot of times, especially depending on the substance use, just being able to meet with somebody and talk about what's going on can help even more than medications. We also have another social worker, Emily Johnson, who is our patient navigator, can help people get connected with other providers, get connected with resources, get connected with housing. We'll also have a nurse with us who can, check blood pressure, check blood sugar, kind of see what's going on with patients. And then we also have a lot of student volunteers who will come with us from various fields. And yeah, we try to get them involved as much as possible, both to help the patients and also to advance the education of the volunteers. So those are all the people who physically go to the Haven, but we also do have a lot of people who are helping us from behind the scenes. So Dr. Adowd is kind of in charge of everything behind the scenes, along with Tracy, the project manager. They're doing a lot of the stuff behind the scenes. Then we also have Kelly Shoreling, another social worker, and then Julianne, who also kind of help make everything run.
Yes, she does. And she also does all of my ordering and makes sure that like everything just works the way that it's supposed to. And that's why I included her, because she's an amazing part of the team. All right, so we start off every day with welcome, right? How can I support you today? How can we support you today? Because I'm not here to tell you what it is that you need. I need you to tell me what you need. Where are we starting at? And the where are we starting at is our initial screening. But before that, with all of the students that come down, I've had lots of social work students. I have a psychology student right now. When UVA is back in session, I will have 2 undergrads that really are interested in joining. Everybody has been vetted. They've had multiple interviews because I am really protective of our clinic. I'm really protective of the program. And I want to make sure people are here for the right reasons. So some things that I feel is very important, and this is my quote unquote social worker slide of in social work school, we are taught to meet the patient where they are. It is my job to guide you, support you, help you navigate the stressors, the things that you have going on in your life, but it is not for me to coerce you into doing something or doing something for you. So when we say we're meeting the patients where they are, this is both physically, meaning we go down to the Haven and hope to expand that soon. But personally, we're meeting you where you're at. Where are you at mentally? Where are you at emotionally? And it really kind of helped guides of where do we start? So we do not require an abstinence-only based approach to care, meaning we do work on harm reduction. Harm reduction has many different facets, and I don't need to go into all of that here with you guys, but we do a harm reduction approach. Engage in non-medical conversation to build rapport. So before our clinic opened, we were out there just talking about what book you read. What do you got going on today? What was something at lunch that you particularly liked? Be a compassionate human, meaning using some active listening and not necessarily having to interject or challenge, because that's not where we're at. Be open to hearing about their lived experience without judgment. Most of the people that utilize the Haven for services all have employment. So they're coming in the morning to take a shower before they're headed off to work. They may not necessarily have a washer and dryer at home, so they're coming in to wash their laundry. So they have clothing for work. So not everybody that uses the Haven is unhoused, and not everybody that utilizes the Haven for services, whatever the services is that they provide, are unhoused because of something that they have done. So use non-stigmatizing language. I could go on for days about this. I've done multiple continuing eds about what does non-stigmatizing language mean. And it's for the whole person, not just substance use. It's really difficult for a patient to be told that you are not compliant when there might be different factors of like, what does compliance mean? why wasn't I able to get that medication? It may be I didn't have the money for the copay. The pharmacy that it was sent to didn't have it, and they weren't going to find out if any of the other places had it. So there might be a reason for that non-compliance. I hate the term compliance, but using that non-stigmatizing language just in general when we are providing patient care, patient support. Being person-centered, meaning you as the person tell me what it is that you want to talk about today, that you need support with. We might, as addiction medicine providers, say the substance is the most important thing, but the patient may say substance use doesn't matter. I don't have any food. I haven't eaten in days, and that's more important to me right now. One thing that I will say, and I'm just so passionate about this, is follow through on your commitments made. If you promise to call, text, show up, fill out a form on a certain day, you need to do that, or you need to communicate that, because if we're promising something and that promise isn't kept, it damages that relationship that we have. Also being flexible, not everything in a street medicine program or a community program is by the book. And we have to sometimes be really creative on how we support our guests. So our initial screening usually is one of our student volunteers or one of the social workers. We have a web-based screening that helps us collect the data that we need. We collect those demographics and their preferred name and pronouns, which we put in a spreadsheet so anyone can go and look and say, yeah, his legal name is John, but he goes by X, whatever that may be. So we all know who we're talking about. Level of education and understanding, like that the understanding of the information that's being presented. Also, how do you learn? Are you a visual person? If you're a visual person, we have a mobile printer. We will type everything up that you need to know. That way you have that physical piece of paper to take with you. If Dr. Legan is going to do like a titrate plan or change any medications, do you want that in writing so you can have it to take with you instead of relying on, that auditory processing? We ask them what they're looking for. Are you looking for some patient navigation, some care coordination? Are you looking for therapy services? Are you looking for life skills education? Are you looking for medication management? And it often changes over time. We might have guests that come in and want to meet with the nurse and talk to Emily about patient navigation. And then over that course of time, as we build that rapport, oh, maybe I do want to talk to Dr. Legan. I got a friend who's got this problem. Maybe I do want to talk to Dr. Legan about something. So those things change over time. We ask about the legal system involvement, pregnancy status, and we also can provide testing there down at the Haven if we maybe don't know or it has been a while since we had a last cycle, just to make sure that if we start you on medications, that we're doing in both the best interest of you as well as fetus. We do that full social drivers of health assessment, and we provide those referrals. How do we help you? If you are legal system involved and you need a letter for OAR or for District 9 or wherever they're coming from, I'm more than happy to write letters stating that you're receiving services in our clinic. For probation, pretrial, and then care coordination, follow-up appointments. If they've been previously seen at the University Medical Associates for primary care, let's see if we can get you an appointment in real quick. And that way, we're starting to address the whole person and not just the behavior. We also supply supplies for them. So whether that is the harm reduction supplies, but I also have, like, you got a headache today, I got, some Tylenol, Motrin. Our nurse is amazing with doing some like wound care and education. Sometimes we get donations for supplies. So we've had socks and fingernail clippers and things that people might need. So we'll provide them with whatever supplies that we may have that might be beneficial for them. All right, Dr. Legan, after I do my assessment, I'm sending them to you. So what do you do?
Yeah, so kind of just average day at the clinic, just showing up, being available. Most of the appointments are walk-in, which really provides a lot of flexibility to patients. If they're having trouble with transportation, if they're got to get other things done before coming to the Haven talking with me, that's completely fine. That they do offer, showers. There aren't unlimited showers. So, sometimes people really might want to, shower as soon as it's open. So we offer a lot of flexibility. And so, sometimes I'll meet people for the first time. We'll do follow-up appointments. Usually at our main clinic, we'll have 60 to 90 minutes for intakes, 30 minutes for follow-ups. But again, because it's a walk-in, that allows us more flexibility. So, I am able to talk with people for longer than, I might in a usual clinic appointment. But also, if people don't want to talk to me for super long, sometimes, the appointments are just like really quick check-ins, like, the medication working, any side effects, do you need refills? So the appointments, the timing can be really flexible. And yeah, I'll send in prescriptions, send in refills. We do urine drug screens ourselves at the Haven. So we collect the urine and then we bring them to one of the UVA labs, and that's not to get patients in trouble or anything. One of it is to just kind of check in to see how things are going. And another part is there's the fentanyl and like just about everything these days. So, for some people, if they're off of any opioids but still using other substances, sometimes it's still good to know if there is fentanyl in their system, because that can react with some medications. Unfortunately for other lab orders with blood, I can put in the orders but cannot do that ourselves. So, there are circumstances where people will have to go to one of the UVA laboratories to get blood drawn. And then I also put in a lot of referrals to other providers. So again, it's really convenient that we have primary care at the Haven Wednesday afternoons, because a lot of people will come and talk with us about their mental health or their substance needs. And then, just naturally the conversation shifts to other medical problems. So it's always really helpful being able to, just let people know that they can come back in the afternoon and kind of get other things addressed.
Yeah, and our patient navigator also stays for the afternoon clinic too. So it is a really great way of trying to like coordinate that care and then like doing the warm handoff for the afternoon clinic. Hey, John came and saw us earlier today, and he really would like to talk to somebody about high blood pressure. So it's that familiar face, the warm handoff, and I think our teams work beautifully together. So some of the other things that social work ends up doing is that community resource connection. Emily is amazing with housing applications. She's such a great asset to the team because that is just not a strength that I possess. She's also really good at helping people navigate the applying for disability in that whole process, doing the financial screenings, Medicaid applications, helping guests choose what managed care organization for Medicaid that is going to be the most beneficial for their individual needs. We can do advanced medical directives. I came from the inpatient side as a medical social worker, and having those advanced medical directives on file for patients who may not necessarily have family really close by is so helpful in helping them navigate care if they were unable to speak for themselves. So that is one of my pet projects that I do, and I'm really passionate about getting our guests their advanced medical directives on file, explaining all of the different parts of it. What does this mean? So you can make medical choices for yourself, even if you're not able to speak for yourself. We do life skills education and therapy nursing, it does vital checks, health management, education, wound care. We have a lovely in our clinic nurse that does our prior authorizations for us. So if we part of the clinic is if the patient wants to do one of the longer term injectables like Sublocade, we are able to get them started on that as quickly as 2 weeks. We want them stable on the Suboxone first, just to make sure that there isn't going to be an adverse reaction. And we are able to use the funding to provide the long-term injectables while we're going through the prior auth process, because that can sometimes take months on end to get insurance to pay for that prior auth. And then the only kind of sticky point we have right now for those patients that really do want the longer term injectables, they do have to come to our West clinic in order to do that. We can't provide the injectables at the Haven. So we coordinate that care, that, the transportation, how am I going to get you here on that day? We typically walk them through what the process is going to be like, so they know right away. And either myself or Emily tries to meet them when they come into the clinic. So again, it's that familiar face. And then walk them through the process of what this injection is going to look like. All right, so since the opening of this clinic, we've had 60 unique screenings, so 60 individual screenings for just determining what it is that they want. Some of the things that we had identified when we applied for the grant with the OAA is coordination of care for pregnant individuals and those that are justice system involved. So 2 of which, when we did the screenings, were pregnant at the time of screening, 2 of which found out later. And we've been able to coordinate care, get them connected to OB, get them connected to Project Link. So for whatever outcome it is that they're hoping with this pregnancy. 15 have been on pretrial or probation services. And of that, because when we're doing that screening, we have it broken down to what substances are you currently using? It gives us a good idea of like, are we going to be able to safely do moderation, or do we need to coordinate like detox services for certain individuals? So nicotine, cannabis, then opioids, methamphetamines, and alcohol, in that order of like the most often that we're seeing when they're when they're doing the screening with us.
And I think a lot of this we touched on. We're running a little short on time. But there was a study in Europe that really talked to experts in the field and established 4 components of good practice when delivering care to the unhoused. And our clinic is really striving to meet these components. So establishing outreach programs to identify and engage with individuals. Like we said, kind of even before the clinic was set up, we had people just going to the Haven, kind of hanging out, talking about things, going to the breakfasts and lunches, really trying to provide care in multiple fields, so addiction, psychiatry, internal medicine, OB, and really working together with the other providers too. So like one of our social workers, Emily, is there Wednesday afternoon, so can kind of help provide a bridge from like the morning, like the addiction and the psychiatry team, to the internal medicine team. Sometimes one of the internal medicine physicians will kind of join us Wednesday morning if there's a particularly complicated patient, and then also important to disseminate information on services both to the marginalized groups and to practitioners. So kind of as part of my role on the addiction consult service, really letting both patients and providers know that our clinic exists, and also letting you all know about the clinic too.
All right, so some of the things for future growth for this clinic, because I'm my undergrad is in business, so I'm constantly doing that like internal needs assessment. I would love to hire a peer recovery specialist for our clinic that comes down there. I would also like to expand the services to further into the community, so not necessarily at the Haven, but I could see Dr. Legan on one of the little scooters. If you live in a pub, like a larger city, there's scooters are all over town that you can rent. I'd like to see Dr. Legan with his little bag of scooter zipping around town. Some additional staff. Our clinic has grown from when we started, and we had a couple of patients to, I think yesterday's clinic, they ended up seeing 6 individuals for medication management or an intake. I saw 2 people for a therapy session, so some additional staff would be really helpful. I'd like to expand to doing more of a syringe service and being able to provide that. And then additionally doing SmART recovery meetings at the Haven on those Wednesday mornings for those that are really interested in the sober social support group. So since we are kind of running short on time, I did put some patient statements in. They've given me permission to share their experience. I told them it was going to be de-identified. One of them was just talking about being really scared about when they first came in, didn't know how they were going to be treated because of the stigma of substance use and prior experience in the health system. And over a course of a couple of months, just building rapport, talking about the books that they're reading, was open to talking about medication management, and then found out they were pregnant. We were able to coordinate the care, and she's happy to share that both her and her partner are sober, and that is something that she is really proud of. And she's getting closer to being reunited with her child. So I'm not going to read them. If anybody wants the slides afterwards, I'll be more than happy to send them. So our future project as part of the OAA is a harm reduction vending machine. We've been in negotiation with the city to have an outdoor location, and we're getting really close to having that MOU solidified, and it will be at the fire station, which is on Ridge Road or Ridge Avenue. For those that are familiar, it's one of the main roads here in Charlottesville. We're going to have the naloxone spray, first aid kits, the safer sex kits, hygiene and dental kits, menstruation kits, the opioid drug deactivation packs, the pregnancy test kits, fentanyl and xylazine testing kits, syringe disposal kits, and I'm hoping in the future that's where that comprehensive harm reduction program comes in with the syringe exchange. The city wanted to kind of see, where are we going with this? Is the community as a whole, are they going to be receptive to what harm reduction means here in Charlottesville? So we're going to start with just the machine without syringes, and then hopefully, fingers crossed, in the future, we might be able to add them. We also have a contingency management project in the works that should be up and running here soon. We've partnered with Dynamic Care for individuals with opiate use disorder and methamphetamine use disorder or stimulant use disorder. Dynamic Care provides peer coaching and ongoing support. The patient completes tasks in an app that's downloaded onto their phone. And as they complete those tasks, they get incentives downloaded onto a prepaid debit card that they can use anywhere. So we're kind of excited about that because that might be incredibly beneficial for some of the guests that, is, actively working, whatever that recovery plan looks like for them. So we're excited to be able to offer that. And that is the end. Do we have any questions?
Well, let me just, everybody, thank you so much, Dr. Legan and Alanna for your comments. I think that, amazing work that you're doing in Charlottesville. OAA is proud to partner with UVA Health System on this and a couple other projects that we're working with on.
Mm-hmm.
And I know that the harm reduction vending machine can be in Virginia. I think it's a little bit more challenging than it is in some other states because of the laws and regulations Virginia has around particularly around syringe services. I haven't seen any questions that have popped into the Q&A, but I would encourage anybody that is attending to type in a question. If you don't have a question, any comments that you'd like to share. We gotta hype these folks up, so any compliments would be welcome. I see a heart coming up off the screen. Any, we'll take dad jokes, whatever you got, folks. We got a couple of minutes. Looks like a couple of positive reactions coming through. So any questions from OAA staff that are on the call? Well, I tell you what, you guys, you knocked it out of the park. We have a comment coming into the Q&A from Marcia Rotifer. I hope I'm pronouncing that okay. Says, great program, what exciting work. I agree. Thank you so much. Charlie, I think we need to add this to our list of sites to go and see in person. And with that, everybody, we will go ahead and wrap up this session of the Abatement Academy. Again, kudos and thank you so much to Andrew and Alanna for your time. We really appreciate it. Again, great partnership, and thanks for all the work that you're doing.